Let me introduce the next speaker. The next speaker is Angelo Papachristos. Angelo is a advanced practice physiotherapist, BSc, BSCPT, MBA, ACPC. He's at St. Michael's Hospital in Toronto, Ontario, Canada. He's a clinical lecturer at University of Toronto, a model of care committee member, the Ontario Rheumatology Association, the sponsorship and marketing chair of AHPA, the Allied Health Medical Professionals Association. He's the chair of ACPAC, which is the Professionals Association of Advanced Clinician Practitioners of Arthritis Care. He's a CATCH site coordinator at St. Michael's. He graduated from the University of Toronto in 1998 from the physiotherapy program, went on to complete the Advanced Clinician Practitioner in Arthritis Care program, which is a postgraduate specialty program in 2006. Completed his master's, his MBA at the
Schulich School.
That's not UCLA.
That's okay.
In business in 2007. I have completed numerous postgraduate courses in manual therapy, exercise, and is certified in medical acupuncture. Angelo has been at St. Michael's Hospital for 17 years. He is one of two trauma centers, which is one of two trauma centers in Toronto area, providing tertiary and quaternary care, as well as being a University of Toronto academic teaching hospital. Currently, he has clinical responsibilities in the area of focus specialty clinics in the areas of early inflammatory arthritis clinic, ankylosing spondylitis clinic, hip and knees assessment center, osteoarthritis clinic, and sports medicine clinic. He's a lecturer to graduate rehab program, medical programs in the University of Toronto, as well as student resident program. He supervises the student resident program. He also consults and lectures industry partners in the area of patient education, optimizing care for patients with inflammatory arthritis, and exploring various models of care looking at enhancing the scope of practice for allied health and improving access for patients. Thank you so much for coming out.
Thank you. There'll be no time for questions. Thank you very much. First, I want to just thank SAA for once again putting on a great patient forum and education forum. I was asked by Elin and the group here to sort of not spend too much time on some of the background research and maybe make some practical suggestions later on. So we were just trying to figure out how to incorporate some of the video and pictures in this presentation in the back there. So bear with us if some of the stuff doesn't pan out the way I expected to. So just to start off, you heard a lot of things this morning about rats and biomechanic stress. So what I'd like to say is we're not going to talk about any of that because there's an old adage in orthopedics and especially in rehabilitation that motion is lotion. And if you forget everything else, just remember that movement is good, and that's what the talk's going to be about. Okay. So the clicker's not working. So there we go. Laser pointer. Do I have to manually turn it? Oh, there we go. Okay. Maybe the batteries aren't working. So first of all, we're going to discuss some reasons of why you should exercise, different types of exercise, and it'd be surprising to figure out when we mean exercise in a general sense, it incorporates a lot of other modalities and things that might not have come up generally in your train of thought. Literature on exercise and ankylosing spondylitis, and we can just group everything into axial spondyloarthropathy or spondylitis. It's really generalized across all of those conditions. We're going to go over some postural and some stretching program, and then we're going to have enough time for specific questions or concerns that you might have. Okay, and we've heard a lot of this in the previous presentation about how AS is a chronic inflammatory disease affecting the SI joint spine as well as the peripheral joints. And we had a lot of questions over lunch about what does peripheral joint mean. Peripheral joints is anything other than the spine, the hips, and the shoulders. So for example, the elbows, your feet, your knees. So when we classify and discuss what the spine axial SPA means versus everything else, just remember that when we talk about axial SPA, it includes your shoulder joints as well as your pelvic girdle and your hips, okay? We're gonna discuss about really what the mainstay treatment was, and prior to the biologic era, really it was just non-steroidals and exercise prescription, which is still valid today. So pre-2000, all you had was really non-steroidal medications, exercise therapies. So don't forget that. And again, the primary objective of therapeutic exercise is to maintain normal postures, increase cardiovascular fitness, and improve or maximize your overall function. Okay, if you look at this is from the ASAS slides, and this is the international guidelines. We have non-steroidals over here. Axial and peripheral disease is what we were discussing. TNF blockers from a medical standpoint is critical, but if you look over here on the left-hand side, education, exercise, physical therapy, rehabilitation, patient associations, again, are critical in the whole spectrum of the disease process. On the other side there, we have surgery and analgesics. So if you look at this picture as a whole, you have sort of the TNF inhibitors and some of the other medical management or the drug therapies, but on either side, you're looking at either surgical alternatives or non-surgical alternatives, which is really basically exercise groups, patient forums, and support groups. Okay, so those are the international guidelines and criteria. What do we mean by exercise therapy? And when we discuss exercise therapy and spondylitis, really we're talking about breaking it down into range of motion of your joints, both peripheral and axial, or the spine itself, flexibility or stretching type exercises, strengthening exercises to the extent that you typically would think about using weights or some kind of resistance bands. Cardiovascular or aerobic conditioning and fitness is critical, and that's something a lot of patients forget, that it's not just the posture and the strengthening. You have to include a cardiovascular component to your exercise therapy or routine. Postural correction in itself is a different class, and depending on where you are in the spectrum of disease, whether you're early on or later on in the disease, you might require more postural education or training. Breathing, this always comes up. Why is breathing an exercise? I breathe every day is what people tell me, patients. I never stop breathing. But a lot of the inflammatory conditions does affect your rib cage as well as your chest, and you can get inflammation in certain parts of your chest, and if anyone's had anterior chest pain or around their clavicles, deep breathing exercises is something that we do recommend. So if they've ever been diagnosed with costochondritis or some of these other conditions, it's important to realize that breathing exercise and breathing techniques are something we incorporate as part of a strengthening or exercise program. And again, I don't want to minimize all of this stuff, but fitness and sports, doing something that you like and enjoy, I don't want to give the conclusion, is probably more important than doing all this other stuff combined, okay? So don't forget, fitness and sports is part of what you need to be doing. What type of modalities do we typically prescribe in physical therapy, particularly for this group? A lot of the literature has been around exercise therapy being supervised, basically one-on-one interactions with a therapist or a chiropractor, etc., anyone in rehabilitation, doing sort of group exercise work, and then unsupervised, basically just reading a pamphlet, doing your own thing, okay? There's a lot of patient education and information sessions that you can do, hydrotherapy, hot, cold, pool therapies. Those are all part of the treatment. These are all things that you might encounter. There's a lot of passive modalities such as ultrasound, interferential current, TENS, laser. You might come across some of these treatment modalities. And then we have sort of more of the traditional manual therapy techniques, mobilization and manipulation. Some of the other terms or exercise therapies that are typically used in this area, you might come across acupuncture or acupuncturist is very common in any of these chronic pain models. Massage therapy, spa therapy, Tai Chi, yoga, and Pilates. So we're going to try to address some of this. What are the benefits? We talked about in the morning about the biomechanical stress model and is it okay to exercise. I want to just emphasize over here that exercise has got a lot of benefits other than just stressing out your joints and potentially causing trauma. Exercise has basically been shown to increase cardiovascular fitness. It's used in reducing or maintaining your blood pressure. It changes your good cholesterol, maintaining bone density. It improves psychological well-being. There's studies in the psychological and the chronic pain world that basically formal fitness and exercise can improve your mood and be very helpful in depression. It can improve fatigue and most importantly, improve your pain or modify your pain. why are all these important? Is because these are the things that matter to you, right? Some of this other stuff, measuring cholesterol, etc., may be important for your physician when you go in to see them and they sort of measure all your blood work. But really, what you care about is, can I function? Are my fatigue levels appropriate? And is my pain better? You know, so it comes down to pain, function, and fatigue for the most part. Okay, so I just want you to remember those, what's important to you versus what's important to a blood test. Recommendations. Everyone says, are there specific recommendations in spondyloarthritis or spondyloarthropathy? And the short answer is no. Okay, there really are not any specific guidelines. The guidelines really, when you look at all these chronic disease states, for example, the osteoporosis guidelines, exercising for 30 minutes, 5 days a week, stretching, stop smoking, decrease your alcohol intake, decrease your caffeine, and increase your vitamin D. If you look at the diabetes guidelines, the osteoarthritis literature, you're looking at the cardiac guidelines, guidelines for chronic fatigue, chronic depression, and fibromyalgia. If you break those down, the guidelines are almost identical. Okay? These guidelines are all taken from the Academy of Sports Medicine, and they're virtually identical across all these chronic disease states. So I can tell you without a doubt that although there's nothing specific for seronegative spondyloarthropathy, they're going to look almost identical to that. Okay? So there's nothing magical about it. We really don't have any good literature. Okay? Why is that important? It's important because you're probably not going to have a significant issue with respect to mortality or death from having spondyloarthropathy. And this is literature from the your American Census. And for the most part, most of the reasons that you're going to have a serious complication or shorten your life is related to heart issues, having malignant disease, getting hit in a motor vehicle accident, those sort of issues, cardiovascular events. The reason I'm bringing this up is the treatment that you prescribe for this is exercise therapy plus your drug therapies, and the guidelines are the same. So irrespective, if you're not going to listen to anything I tell you about ankylosing spondylitis, if you want to live a little longer because of heart disease, osteoporosis, or not limit your impact of having any of these chronic illnesses, do it for one of those other reasons. Okay? They're all the same. Now, how much exercise is recommended? You already saw on the slide there, 30 minutes, 5 days a week. How much does an average person in the US exercise? This was a study taken from your census. It's 2007 data. But if you look at it over here, being inactive, semi-leisurely, and regular exercise. Inactive means doing less than 10 minutes of moderate activity per week. 10 minutes. Okay? That's a third of the population does less than 10 minutes. It's a third, a third, and a third. A third of the population does 10 minutes. A third of the population does at least 10 minutes, 2 to 3 days per week. And then the recommended guidelines would be over here, about 1/3 of the population will do 20 minutes, 3 days a week of moderate intensity of exercise. So you're not alone, because a full 66% of the population isn't doing the minimum requirements for any of those other conditions that may impact your life. Okay? So keep that in mind. What type of exercise is everyone in the US doing? Again, this is orthopedic literature, but for the most part, walking. You know, don't forget, brisk walking is a form of exercise. It's something that you can incorporate. These are sort of percentages of individuals reporting what they do on a day-to-day basis for exercise. You can see walking, gardening, stretching, swimming. These are sort of broken down by condition, and I can give you some of that information. But don't forget, I wanted to point out that walking, a good 44% of people consider that as the mainstay of exercise, and you can use that for aerobic workout. Some more literature on why is it important. We're talking about exercise therapy and cardiovascular events. There's been numerous papers published really on increased rate of cardiovascular disease in patients with ankylosing spondylitis. So if you're not going to do it to protect or maintain your mobility or your joint function, there's multiple papers that basically cardiovascular disease is more common in AS than in the general population. AS is a disease with a strong influence of comorbidities affecting the total burden of disease, meaning that having inflammation in your system predisposes you to some of these cardiovascular risk factors such as heart attacks, etc. The treatment for that, again, drug therapy plus exercise. The exercise therapy is the same as the other guidelines that I brought up earlier. Okay, exercising 20 to 30 minutes, 5 days a week. I'm just trying to build a case here, okay? A theme, a general theme. So now you're going to say, well, what happened in all these randomized trials? There's really been a lot of randomized trials and reviews in physiotherapy literature and rehabilitation, but very few in inflammatory arthritis and ankylosing spondylitis. Okay, and the reason for that is we don't have large pharma corporations wanting to sponsor sort of this alternative non-drug therapies, which is fair. They're not in the business of incorporating that into their drug trials, except recently. Okay, at least in the FDA over here, a lot of in the last couple of years, there's been this emphasis of, if you're going to do research on some of these drug therapies and TNF inhibitors or any new drug on the market, they're looking at patient-reported outcome measures. They're looking at more of sort of all these other influences other than just the drug itself. So they're looking at some exercise, they're looking at fatigue levels, they're looking at sleeping patterns. They're looking at whether a patient on a certain medication is more productive at work. So we don't have that literature yet, but I think there's the trend to start including this as part of these larger trials to see whether you're on a certain medication, whether you're exercising, whether you have improvement in fatigues, whether you're able to productively work in your environment. So I think over the next couple of years, that's probably going to be included. Okay, exercise programs and trials with ankylosing spondylitis, do they have potential for effectiveness? This is all that's out there. This is a recent literature review, and really there's 12 articles or 12 trials that looked at over 800 patients in ankylosing spondylitis. Only one of them met the American College of Sports Medicine recommendations for intensity, duration, frequency, and length of exercise period. So they've done 12 trials, and only one of those met those minimum criteria of exercising for 30 minutes, 5 days a week, and doing the strengthening component. So what kind of recommendations can we really put forth? It's tricky. Other literature, we're going to just go through this really quickly because I think you want to see some of the more practical aspects of this. There's been studies in the past on outcome measures of just doing exercise, home programs, etc. And they've studied that even doing a home-based program in ankylosing spondylitis, being given an exercise sheet and just complying with that can improve what we call your self-reported mobility scores as well as aerobic exercise component. So just doing even a home exercise program on your own, off a piece of paper, like you can get back from the SAA table right there, that in itself can provide you benefit. Okay, so it might just be a little bit that you need to sort of swing you over to that improvement category. Intensive inpatient therapy. In the past, we used to have inpatient units where you used to be able to admit someone, force them to exercise for 3 weeks in a hospital, and they measure what happens to them. Unfortunately, at least in Canada, that's never going to happen because they've got rid of all inpatient beds in rheumatology. And I'm sure the same is in the US. Everything's outpatient based because of cost. So when they did allow patients to sort of focus on themselves for 3 weeks and exercise and stretch and perform a program, what happened? There was no changes in their inflammatory markers. That's the inflammation that your physician measures. However, things that matter to you, for example, neck mobility, spinal mobility, and fitness improved measured 15 months out. So maybe your inflammatory markers didn't improve, but your mobility improved just by doing 3 weeks of exercise over a course of 15 months. Okay? Another trial that was recently done, randomized 100 patients in AS. Basically, they're trying to replicate this doing 8 to 12 repetitions of interval training, hot water pool, Nordic walking, 40 to 60 minutes. I just highlighted that just because Nordic walking has become quite popular, at least in Europe and as well as in Canada. And that's really walking with those little Nordic sticks that you're walking out there. It's just brisk walking, and that's what it means. And again, it's the heart rate that's important. Again, trying to make it cardiovascular impact. And again, they found that improvement in your BASDAI score, that's something your rheumatologist measured, over one period, you maintain those scores in improvement in pain. So just by complying with a simple program, you had those improvements a year out. Okay? We listened this morning about different sort of countries or continents doing different things. Okay? In North America, we have one philosophy. In Europe, this is a Dutch study. Again, what they did was they looked at patients doing control therapy, exercise, and then this spa exercise group. And what they found was, after doing this 1 week of a spa therapy program versus looking at non-steroidals, this is sort of pre-biologics, the results were maintained over a 40-week period. So you had improvement in, a lot of the measures related to mobility, pain, and function. So you're going to say, what is this spa exercise group? Spa exercise group was stretching program followed by a walking program. Okay, so think about doing a stretching class for an hour, then going on a walking program for about an hour. They did hydrotherapy or pool exercises for about an hour. In between, they looked at their wellness, so they had a dietitian look at sort of nutrition, making sure that someone like Angelo wasn't going to go in there and have something inappropriate for his cholesterol levels, healthy diet, etc. And then they put him in this sort of chamber in this cave, which was a high humidity, high heat environment. Okay, and this was what their protocol was. And they found that these patients were better after 1 week. Okay, so what is that? And they maintained that for 40 weeks. So really what this chamber was they found that back during the war that they had miners with arthritis going in mining for gold back in Austria, and they come out, they'd be feeling better. These caves were emitting low-level radon gas. So that was a form of treatment back in early days for spondylitis. So sometimes, things in the past that have sort of come back. Now, I'm not recommending that anyone go and radiate themselves with radon gas, but what I'm trying to impress upon you is that focusing on your fitness and well-being for 1 week can give you benefits 40 weeks out, okay, and maintain that benefit just on exercise therapy alone as well as a non-steroidal. Now think of that just for a minute, and then think of being on that plus one of your TNFs if you're on that. What's the synergistic? What's the synergy between those? And there's some interesting trials coming out this weekend at the American College of Rheumatology where they're looking at, are patients better on TNFs if they're exercising and non-smokers, etc. So they're looking at the synergistic effects of some of these. Are you better on the medications if you're a patient that's complying with some of these? Just to say, personal experience, that's me. Went to Europe last year, Blue Lagoon in Iceland. It's a hot geothermal spa. One afternoon, I felt great for about 4 weeks, okay? My low back pain completely disappeared. High heat, high humidity, there's something to be said about that. Earlier this morning, we talked about biomechanical stress, and we mentioned rheumatoid arthritis. Is something physical or during a flare, is that going to cause you difficulties or problems? We don't have anything in AS yet other than that biomechanical model that was presented this morning. However, if you look at the rheumatoid arthritis literature in the old days, meaning 2000, which wasn't that far ago, they exposed patients with rheumatoid arthritis that were in an active flare in hospitals with an intensive exercise program. So even though they're hurting everywhere, they felt stiff, they felt painful, they would put them on an exercise bike. They would make them do their exercise program during that time. And they really found that the patients that exercised during their flares and those that didn't, the ones that exercised maybe were marginally more painful for a week or two, but in the end had better outcomes than the ones that did nothing and had bed rest during that period of time. So there's nothing really to state that during a flare, if you're going to just do moderate type of exercise, that it's contraindicated, okay? And we're just extrapolating this rheumatoid literature to spondylitis, same principle, okay? Trends in AS. So hopefully now I'm building this case that exercise is good for your joints, it's great for your spine, it's great maybe for cardiovascular fitness, it's maybe going to prevent some heart attacks, osteoporosis, etc. If it's that critical, what is the literature surrounding patients? Okay, 21% of patients with the AS reported no exercise per week. 0, none. Okay, these are just some studies. Moderate exercise we know might be beneficial. And what the recommendations are, focusing on consistency, not the quantity of the exercise. So just doing it on a regular basis, okay? But a big percentage of patients in a condition that exercise therapy is a mainstay of treatment is shocking to a lot of us. But these are the facts. This is the data. Adherence to an exercise program was not influenced by marital status, employment history, or family history of AS. So even if you had a brother, sister, mother with AS and you sort of knew long-term what would happen, that didn't change your mind on whether your compliance was going to go up. Adherence to the regular exercise program was associated with having a regular rheumatologist follow-up, beliefs in the benefit of exercise, as well as a higher educational level. So if you had a routine follow-up and kept your appointments with your rheumatologist or your physician that's managing your care, that was associated maybe with better compliance, maybe because you had someone continually enforce over and over the importance of doing some of this stuff. Believing in the fact that after this talk, maybe I can convince some of you, more than 21%, to exercise for those reasons that we're talking, as well as a higher education level, just because they found that the correlation, the higher the education level, the more persistent probably they were with getting medical care. Okay, so that's what it's influenced by. Most common reasons for not exercising or reporting not to exercise, I'm not going to go through everything here, but lack of time and fatigue. So don't have time to do it, too tired to do it. Okay? There's another study in 2010, exercise habits amongst AS patients. 40% exercise takes too much time. Okay, these are beliefs from patients. Exercise is hard work. Okay, it's not an injection, it's not a pill, it's too difficult. I can't keep up with it. I'm fatigued by exercise, okay? Exercise tires me. And this one right here, family members not encouraging me to exercise, 20%. So we have to change some of the beliefs around fitness, exercise, to maximize your overall benefit. You know, one key aspect that's critical is to look at the drug therapy, but your outcome for functional mobility is going to be interlinked with whatever else that you have to manage on your own. Okay? Now, we sort of broke this down into some key recommendations. I'm just going to summarize this. The bottom line is what we recommended in our clinic is that you have to do a minimum of 200 minutes per week of exercise on a weekly basis. And if you do under that 30-minute mark, there's probably not going to be much improvement. So 200 minutes per week is sort of our target. Okay? Broken down, that's about 30 to 40 minutes if you do it 5 days a week. Back exercises done 5 to 7 days per week if you've had the disease greater than 15 years is the recommendation. So if you've had the disease for a long period of time, you might have to focus more on spinal mobility, postural exercises, etc. Okay? If you do them less than 3 days per week, you're probably wasting your time. So again, consistency is critical. Tai Chi, there's really nothing in AS and Tai Chi, although it's done quite frequently. The literature surrounding is mostly in geriatrics or in orthopedics, where we found that Tai Chi is beneficial in balance and balance retraining, etc. And nothing in spondylitis. However, if you extrapolate that to rheumatoid arthritis, patients that do Tai Chi have found that really it doesn't exacerbate any of their symptoms. So it's a safe type of fitness exercise that you can do. Okay? There really wasn't any quality reviews or evidence on Pilates and yoga as a form of exercise therapy. However, routinely, we recommend and advise patients to do Pilates, okay, because it's really an excellent form of fitness and training for your core muscles. Okay, so that's one recommendation that if you want to pick one sort of, not sport, but hobby, Pilates would be the one that we would try to skew you to, just because it works on mobility of the tissues, it works on core strengthening of your spine, and it's nothing that's going to put enough impact in your joints to cause any trauma. There's recent guidelines that are just presented. These are the new American College of Rheumatology guidelines on treatment for spondylitis. I'm not going to go over them. Just know that these were just published in 2015, and they're going to be discussing this weekend on the treatment of spondylitis and non-radiographic SPA. What the recommendations are by the panel is really that they strongly recommend treatment with physical therapy over no treatment with physical therapy. Okay, so that's really what we're saying. They're recommending do something over not doing anything. Okay. Really, they are recommending active interventions over passive interventions. And what is active interventions? Active interventions are things that you're doing on your own, the fitness, the strengthening, the cardiovascular work, over the passive modalities such as the TENS, the hot packs, sort of the ultrasound treatments, the treatments that you might be getting at a sports clinic that are done to you, not something that you're doing on your own. So we want you to be active and fit versus having the passive treatments that you might get at a sports clinic, okay? Passive interventions can be used. They're just there to supplement for a specific condition during a very short, limited time frame. For example, if you ended up with a rotator cuff tendinopathy, or a single joint like your knee or your foot, maybe passive modalities for a limited period of time are indicated. So we're trying to emphasize active versus the passive. Things that you're doing versus things that are done to you, okay? Again, we've mentioned some of the aqua fitness in the aquatic therapy in the warm water pool. Their recommendation really is preferentially land-based exercises versus pool or aqua fitness. And really, although the literature was demonstrated to be a little bit more positive for the aqua fitness or therapy, the recommendations were made strictly because access to pools is difficult. So the recommendation is to do more land-based, just because most patients might not have access to a pool, or at least a warm water pool, okay? But again, I heard there's a nice hot springs or hot spa a couple hours north of San Francisco. Dr. Gainsler was mentioning that. Feel free to do whatever you have access to, okay? The only other recommendation that's relevant other than the drug therapies that's new is this, and we'll talk about this maybe in the Q&A, is there is a recommendation for patients really against spinal manipulation, okay? That's something we've been recommending for years. However, it's a strong recommendation now in the published guidelines that if you've got spondylitis, particularly if you've got restrictions in your spine, syndesmophytes, etc., you got the bridges, we would try to strongly encourage you not to have someone have spinal manipulation on your neck, thoracic spine, your mid-back, or your lower spine, okay, just because of the risks. Okay, so just the early conclusion on that part, it's generally accepted by all the American, European guidelines that exercise is a mainstay treatment of treating ankylosing spondylitis in combination with your drug therapies. It's desirable to have a stiff spine in a more optimal position versus being stiff in this position. For example, if you're going to get rigid or stiff in your joints, you might as well be in an optimal position, upright, where you can be functional, okay? And we want to emphasize now the importance of the cardiovascular fitness, which is something that's just new. There's all these comorbidities with having a chronic inflammatory disease. It's not just the joints, it's not just the spine. You have to worry about all the impact of long-standing inflammation has on your cardiovascular system. Some of that is being managed by the drugs that your physician will give you, but a big component of the exercise guidelines for cardiovascular disease is exercise therapy. So another reason to do your 5 days a week of moderate intensity exercise, okay? You should participate in therapeutic exercise as well as recreational. Therapeutic exercise is something you would come in, see your therapist or your chiropractor, and they would prescribe, doing these posture exercises. But I think recreational exercise is critical here. You have to be compliant, you have to do something that you like doing. There's no point in coming to me and saying, don't get me in a pool because I don't want to be in a bathing suit. I don't know how to swim, right? But I love to run, or I love to do Pilates, or I love to play soccer. It's our job, or the professional job, to sort of modify the program to get you to do an exercise or a program that's going to fit your lifestyle. Because if I think you're going to do it, or you enjoy doing it, the likelihood goes up that you will do it in the long run. Okay, so try to find something that you enjoy doing and discuss that with your therapist, because it's critical. There's no compelling evidence that exercise during a flare, so if you feel terrible, you're a little stiff, you're having a little ache and pain here, there's nothing to say that continuing on with a moderate exercise, like a non-impact type of activity, is going to flare your disease or cause long-term damage. Okay? Long-term damage versus short-term pain. There's a difference. You might have a little increased pain, but it's not going to cause long-term harm. Okay? Disease-specific protocols are not available in the literature. There's no magic, do these 10, and just do these 10 every year for the rest of your life, okay? There is no such magic formula. It's about finding things specifically to treat the individual with caveats, as long as you hit all those targets of cardiovascular fitness, stretching, range of motion, exercise, and we'll go over some of them, okay? There's no evidence that exercising will increase inflammation when performed at moderate levels. In the past, there was this fear that if you're a marathon runner and you're doing high-intensity exercise, maybe that might increase your inflammatory markers in the body. But those studies were really sports medicine studies looking at people that are running 4 or 5 hours, at high intensity. That's not the normal average American. Okay, that's a very isolated group, and if you can run for 4 to 5 hours at that level, I think you can handle a little inflammation. Okay, so let's just put it that way. Some of these studies are done on the extreme to show a very marginal uptick in an inflammatory marker, and then we all worry about it. Don't worry about it. Okay. Large percentage of AS patients, particularly women who are not engaged in any form of therapeutic exercise. Those numbers and that data that I was showing you really was data just generally, but they found when you break it down into women, it's greater. Greater number of women are being missed in the initial diagnosis, greater number of women are missed in sort of formulating a treatment plan or an appropriate treatment plan, and greater number of women are not participating in therapeutic exercise. So it's something we have to sort of keep in mind if you're a friend, family, or clinician, just to keep an eye on sort of leveling the playing field there with the education. What we recommend, again, is 200 minutes of exercise, so it's 40 minutes 5 days a week, or you can break it down. Doesn't really matter, but you need to do that sort of magic number that we recommend just to sort of get the minimum, okay? Do some posture exercises, aerobic exercise, 20 to 30 minutes, okay? And range of motion exercises of your joints, meaning that if you don't move something through a full range of motion, after a while you lose a few degrees here and there, particularly, for example, your neck, your spine, etc. You know that. Okay, that's probably something you've noticed over time. So we try to encourage that you hit all those recommendations. Again, my belief is consistency of the exercise is more beneficial and key, not the intensity. I don't want you going out there and saying, I haven't done anything for the last 10 years and now I'm gonna go running the next 5 days because I gotta make up for lost time, okay? And we're gonna go through some of those. It's doing something on a consistent basis, marginal improvements over a long period of time. Okay, so you do not get increasing in symptoms, you don't get increasing in pain, and you don't give up. A lot of the time, any new exercise program, the highest failure rate in any of these chronic pain programs and exercise programs, because you've done things too quickly, and you get a flare, you worry that you've caused some harm, and you give up, and you stop doing the program. Okay, that's typically what happens. So try to be consistent, okay, for the long haul. There's lots of guidelines here. There's brochures in the back about exercise therapy, etc. There's the European and the British have the NASS, the National Ankylosing Spondylitis Society. It's great. It's online. There's a PDF of it. Very detailed information. So there's very good guidelines that you can go online and just that you can pull down and just get started even this afternoon. Okay. We're gonna break, and I'm gonna show you just a quick video. Takes about 3 minutes, and then we're going to go through some specific exercises. This is a quick stretch video that we made just with one of our staff members who has degenerative arthritis. Okay, Willie, and he's a fit 55-year-old. Okay, but he's got extremely stiff spine. And it's something that we encourage patients, particularly if you had a sedentary job. For example, most of the time we're sitting around in the office or on the computer. We're in this sort of forward head posture. We're in this flexed position. Everything we do is sitting all day. And the recommendations for someone that has back pain is to get up every hour and do a stretch. So if you're an administrative assistant and you have neck pain or back pain, we tell you to get up every hour or do a quick 5-minute stretch. The same should be applicable to everyone in this room. Okay, so what we did with Willie is did a quick 2-minute video. It takes about 2 minutes that he does every 2 hours. He doesn't get around to it, but every 2 hours he does this little routine, and it hits all the key areas of neck, thoracic spine, which is your mid-back, and your lumbar spine. Okay, and I'm just going to show you, and then you get an idea of what we're doing and what an exercise program that you can incorporate daily would be, and we'll go through some specifics. And hopefully this works. Okay, here we go. And hopefully I can pause it as well. So you're sitting in a chair in an optimal position, and all Willie's doing right now is just bringing his arm behind his back and just extending or retracting his shoulder blades or his scapula. And what that does is just open up your chest wall and your pectoralis muscles, okay? So that's step one. It's working. Then you stand up, because what happens here is you're extending your hip flexors. After sitting, for 8 hours straight, that you are today, you're sitting at 90-degree angle, your hip flexors start getting affected. You start getting tightness in those muscles. So you stand up in this position, you make a little triangle like this. Willie's then going to raise his hands up over his head to get his shoulder motion going. And what he does is at the end is he pushes up towards the ceiling, okay, just so you get that extra little chest expansion. And he takes a deep breath in and deep breath out. So that just encourages you to open up your chest wall and your chest expansion. So he's doing the deep breathing there, brings his arms down, sits down. So you're getting your motion of your hips, okay? This, all he's doing is moving his neck. We call that side flexion. You're just trying to bring your ear over to your other shoulder, okay? And then he's going to do the opposite side. Okay, you can see how he's even lifting up his shoulders so tight. As soon as he does that, his whole shoulder comes up. After he's done that the second time, he just leans over with his arm opposite side and just gets thoracic expansion, lifts his arm up to get about 120, 140 degrees, and then you're just looking towards the tip of your thumb. Okay, so you're incorporating rotation of your neck at the same time you're doing your side flexion of your lumbar spine. Okay, and he does that on the other side. You can see how stiff. On this side, actually, you can see it's less because he's got a rotator cuff tear on one side and his arm's not functioning as well as it should. Then crossing over and working on your thoracic rotation, okay? Both sides. A little stiff, okay? Before you do any of this, if anyone has a hip replacement in the room, don't do this. Or at home, don't do this. Do this with caution, okay? Typically, some patients with ankylosing spondylitis, some of the joints that are typically replaced in orthopedics are your hips, or if you're older. So just be cautious when you're doing this. Get clearance from your therapist. And what you're trying to do here is bring your hip into a flex position, externally rotate the hip, and you're just working on stretching the capsule in the hip just to free up that motion, okay? So this is a typical stretch that we would incorporate. So if you don't have a hip replacement, you can do this. And all he's doing is putting his hip up there and then pushing down on his knee. And stand up again, frees up the motion. We always encourage you to do this, which is a hip flexor stretch, to do this holding onto a chair so you don't tip over, okay? And I'm just gonna pause to show you. So what you do is you stabilize one of your knees there, and then he leans forwards, and what you're stretching is your front of your hips, your hip flexor muscle in this position, okay? And he's gonna rotate to the other side. He's not as good as on that side. I didn't cue him on doing this. I just do what you're normally doing. He's rushing through a lot of the motions. He's working on his hamstrings over here, just maintaining your trunk straight and then leaning forwards with your chest versus bending at your thoracic spine, and you're just stretching out your hamstrings in the back, which get tight. And once you get the hang of the routine, it literally takes 3 minutes, okay? And he's gonna stand there, sit down, again. So this is all he does every 2 hours at the desk, okay? And incorporates all the motion. Okay, I'm trying to move on. Okay, that's our 3-minute sort of exercise program. We're gonna move into some of the static pictures, okay? Why do I have this over here? Willie's a smoker. And this is my anti-smoking campaign, okay? We've been promoting smoking cessation for years, both from an orthopedic perspective as well as inflammatory disease. You've heard it this morning, you're going to hear it again. If you're a smoker, ask for help if you can't to try to stop smoking. First of all, it's the benefits of smoking cessation are been shown in multiple chronic diseases. Okay, it's been also shown in ankylosing spondylitis, and you heard that this morning, that people who smoke have worse prognostic outcome having ankylosing spondylitis. You respond maybe worse to some of these TNF medications if you're a smoker. Your pain and chronic pain literature, if you're a smoker, your pain symptoms are less modifiable if you're a smoker. Okay, so if you're a smoker, basically you do worse prognostically as well as response to any of the treatments that we have. From an orthopedic perspective, at least up in Canada, if you're a smoker and you're obese or overweight over a certain threshold, you're also being, you're influencing the amount of orthopedic surgery you're going to be entitled to, because smokers, diabetics, and obesity don't mix with healing. Okay, so at least in St. Michael's Hospital, the fact if you have a BMI of over 40, you're diabetic, you're a smoker, you're likely not going to get your knee replacement or your hip replacement because the outcomes are worse. Okay, so now we're limiting potential therapies, okay, because the outcome is worse. So we're trying to do something that's going to help prevent sort of complications and infections. I'm going to go through some quick tidbits because Elin wanted me to talk about some practical aspects, okay, not just the literature. Sleeping positions come up year over year. So this is poor sleeping posture, okay, for those who haven't figured that out. So what's going on here? He's got 3 pillows, his neck's in the flex position, and he's also rotated. The number of pillows that we typically recommend is the fewer, the better. So if you've got a forward head posture and you can't get flat up against the wall, then you have to try to use pillows to modify and accommodate that position to lie in a supine position, which is this, lying on your back. If you can get flat, we recommend that you sleep with the minimum amount of 1 pillow or 0. So if you can sleep with 1 pillow flat, that's what we recommend. Okay, this is looking at it from this side. If you're a side sleeper, okay, you can see how much his neck is sort of tilted to the opposite side. What happens is one side gets tight, you start compressing all the structures, the other side gets stretched out and painful. Okay, you're lying on your shoulder and that becomes painful as well. So if you can lie with 1 pillow, it's probably better for you. Now, what's this? He's extremely pleased to be holding up our model of these cervical pillows. Okay, they're called cervical pillows. You know, Obisform has them. They're just marketed, and really all they do, if those who can make it out, is it's got a little wedge. Okay, it's a foam pillow with a little cutout in it. Okay, I'm gonna go back. You can see that little dip over here, and what they're meant to do. And there's different types. It doesn't really matter. The principle's the same. It should really accommodate your neck when you're lying on it, to accommodate it so you're not flexed or extended, so your head or your occiput sort of falls into that dip, and you have support on the back of your neck, and it keeps you from going into a flex or extended position. So you can see his alignment here is much better on this pillow. There's different types, but this is the optimal sleeping position. Looking at it from the side, you can see what happens here. His neck posture is perfectly aligned with the rest of his trunk. There's no bend in his neck. You can see what happens is this wedge over here gives a little bit of support on the side of the neck here so the spine doesn't collapse. And the rest of his occiput, because you got all this other stuff here, falls into that little groove. Okay? That's the position that we typically want to accommodate to you. This is looking at it from the side, and just to point out that he's got good positioning over here. His shoulder is less than 90 degrees and sort of tipped out in this position, and what happens is that prevents you from getting shoulder impingement or problems with lying on your side and getting shoulder pain. So this is the typical position if you're a side sleeper that we would recommend. Now everyone's gonna say, well, what if I can't find a pillow or purchase a pillow? You know, that's okay, because we'll show you a quick and dirty way to do that. This is looking at it from just a supine position. You can see his position is well aligned. Next, patients ask, how do I get out of bed when I have? So these are sort of practical tools, okay? How do I get out of bed? And this is what we recommend. Oh, if the video works. Hold on. Yeah, it's working. Okay, so this is our log roll. So you're gonna roll over to the side, keeping your head in the neutral position. You put your hand under your neck. You can see right there, he's pushing off, and you roll or sit up in a unit in one block. Okay. Next question was, how do we get out of a chair when I'm having a flare? So some practical reasons, because occasionally you'll have some symptoms and you just won't feel like getting up, or you're tired, or you're very painful. If you have hip pain, how do I get up? Or how do I get out of a chair when I have back pain? This is the way we recommend. Maybe I can even pause it here, hold on. So you scoot to the front of the chair. You bring one leg in front of the other, okay? You lean forwards, okay, it won't pause. But you lean forward basically until your shoulders are almost over your knees, and on a rocking motion, you push off your knee. It's just the most efficient way of getting up out of a chair without using that much energy. What do we do next? So you've got out of bed, you've got from sit to stand. Next part of the program is we stretch in the morning. Okay, this is Willie over here doing his gastrocsoleus stretch. Okay, so we want to stretch because after this he does his walking program with his Fitbit for 35 minutes, okay, to work. So you can see how if you're stiff in the morning when you wake up, you have to get to work. You don't have time to do a whole fitness program. Get out of bed, get in the shower, do your stretches, get your Fitbit, and go. Okay, you're gonna get your 30 minutes of exercise right there, at least the one early in the morning. Okay? This is just a note for myself. You gotta start low and go slow, okay? Concept. Second concept, document and track your program, including when you started or when you've made any changes. It's critical, because if you started something at the same time you started a medication that your physician gave you, occasionally you might have increasing in pain, increasing in symptoms. You go 3 months later to have your checkup and say, I'm not feeling very good on this medication, I'm no better. And you forget to tell them that you've also started running at the same time. And we can't really put those two together. If you started any exercise program or made any changes, document them so we can actually modify it and see whether it's the exercise or whether it's the natural history of the condition. Okay? It's something we always forget to tell you. The other thing is, prior to starting a program, make sure you tell your family physician or your rheumatologist or your physio that you know what you're doing, to make sure that if you have a hip replacement, you're not going to go back and do that exercise video that I gave you, and we're going to modify it. Okay? So how much exercise? After you've done your little walk, if you don't want to do your Fitbit, we recommend non-impact type of activities, elliptical, cycling, etc. Okay? If you're starting a new program and you're not active, like 66% of the population, okay, we're going to start you at 10 minutes a day. And we're going to increase 1 minute every week to target 30 to 40 minutes per day. So really slow, okay, gradually. Why? Because we don't want to aggravate. We want your body to accommodate. We want you to sort of get into a regular routine. We don't want it to be onerous on you to incorporate in your work day or home life. If I tell you to go do 2 hours of exercise, you're not going to do it. I wouldn't do it. So if you're starting a new program, 10 minutes, cardiovascular, get on the bike, increase it by a minute every week for your target of 30 minutes. Okay, so you're looking at a long period of time. So 4 months, 6 months out, you're going to hit our target. Your body has enough time to accommodate to that stress. Okay, if you talk to an orthopedic physio or a rehab specialist, this is extremely low. Okay, we'd start you at higher intensity than this. Okay, but not in inflammatory arthritis. We don't want you giving up because you start getting symptomatic. Neck retractions. Everyone keeps asking, what is a neck retraction, which our therapists keep prescribing. So I'm going to try to show you, hopefully. So this is a postural exercise to try to get your neck, which is not working. Hold on. If it doesn't work, I'll have to show you. Okay. So this is Lee trying to do a neck retraction. Okay, and you can see what you're trying to do is get your occiput ear back over the rest of your spine. So when we say neck retraction, we're not coming in, we're not extending back. It's sort of a straight back motion of just trying to get your head or neck over in a better alignment. And that's something we recommend you do every day. So that's what a neck retraction is. When you look at photos online or on the brochures in the back, you can't figure it out, that's what that is. It's sort of a fluid motion backwards. Side flexion over here. Any of the repetitions when we start doing an exercise program, we recommend, again, very low. We start with 5 repetitions. It's really low. Most of the time you go to the gym, you see a therapist, they say do 3 sets of 8 to 10. I'm saying do 5, okay? You hold each position at the end for 2 to 3 seconds. Increase by 1 rep a month, per month, to your target of 10 to 12 reps. Because I want you to spend half an hour to 40 minutes doing an exercise program and maintain that for years, okay? I don't want you giving up. So if you start low, you'll get through the entire program, you'll fit it into your day, and you'll get benefits, okay? So start very low and just increase gradually. This is easy exercise you can do at the office or home. It's just really making sure you're lined up, okay? It works on balance on the other extremity. You're bringing your hip up to 90 degrees. You're counting to 3, 1, 2, 3, and down. And you do that 5 times each, and you move on to the next exercise, okay? There's a cat stretch over here. Again, so you can go onto your mat work. These are all stuff you can do at home within half an hour. Oops. Okay, that was the cat stretch, which is not working now. Sorry, the computer is... Okay, maybe we'll do the rotation. So this is lumbar rotation. So you're lying on the mat. You're trying to rotate from side to side. Now, if you can't get to that position, you just go as far as it's comfortable, okay, and you gradually improve over time, okay? So this is what lumbar rotations look like when you're on the mat. You can do that at home, on the bed, or on the floor. We prefer a more rigid mattress surface, okay? Willie's doing bridging. This is what bridging looks like, okay? Again, you're just trying to extend and lift your pelvis up off the ground. He's flexing his neck quite a bit here, so for him we would correct this and say to try to lift his legs out a little further so he's in a better position and not putting strain on his neck. But this is a bridging exercise. This is prone lying. Prone lying is something we typically continue to recommend. It's something you look in the literature and in the documents if you go online. This is what prone lying means. Really, it's just lying on your stomach, okay? Prone is just really lying on your tummy. And the reason for doing that is, again, most of the time, you're in a flex position. This is the typical position. Your hips start bending, your knees start flexing, and you start getting into this position. Everything, gravity is in that position. So we recommend that you lie prone, and when you lie prone, at least once a day, you're getting a stretch through your hip flexors. You're extending your spine, so trying to reduce some of that gravity, so some of those things that gravity has done to you all day, okay? And we recommend you maintain this position for 1 minute, okay? And you say 1 minute. Yes, some people are so stiff that if you lie in there and put a timer, 1 minute is a long time, okay? 1 minute, and then you increase 1 minute per 2 weeks with a target of 10 to 12 minutes per day, okay? Again, a lot of variety and mobility in this room. Younger patient, no restrictions, you might be able to get up there. But if you put a timer, you're gonna see 5 minutes is a long time to sit there in this position. Okay, most people say they've done 5 minutes, 10 minutes, but it's actually about 2 minutes. Okay, so this is prone lying. This is Lee doing prone lying again in a position, but he's got more mobility, so he's trying to extend a little bit further. If you can't get to that position, it's okay just to start off with a little bit lower. If you don't have the neck mobility, you can see what happens here with Willie. He's just putting his hands on, keeping his neck in a good position, and he's getting some extension through his lumbar spine there. If you can manage, again, just modifications, things that you can do easily at home. You just put a couple of towels under the forehead, you're keeping your neck in a good position, so you're not rotated, and rotation is usually what most patients get difficulty with. It's hard to sort of lie on your stomach and keep your neck rotated in that position. And you're just lying there, and what he's going to do next is just in that position retract his shoulders back. Okay, so you're working on trying to extend the spine as well as work some of those periscapular muscles to get some of that extension through your spine. And again, you're just going to do 5 of those and move on to the next exercise. This is Willie. I could never get him into a pool. Even though he's from the Philippines, lived by the water, never learned to swim. Okay? So Willie's exercise is to lie on a mat and practice prone lying with reciprocal swimming motions, okay? Because you're getting neck rotation at the same time you're working your spinal muscles. So we can modify almost anything to accommodate your situation. A little bit more challenging over here with Lee, again, working his core. This is looking at a either a Feldenkrais roll or foam roll, very common, or you see them at gyms now all the time. Again, working the core, lying on this foam mat actually applies a little bit of a pressure posteriorly when you're putting your weight on it, and again, it extends your spine from below. We just say, sit there for 10 minutes, Willie. Keep your arms back and forth in that position, and then he does his leg extensions. Okay, this is Lee doing the same thing, but we've incorporated more of a core program here. Oh, almost done. Just to give you ideas that you don't need to spend a lot of money or time going to a gym. You can incorporate this with, here we go. So he's on the foam roll, brings his arms up to 90 degrees, 2-pound dumbbells, okay? Extending, he holds, does his breathing in and out, and he's back up again. Okay, and he's gonna do that 5 repetitions and move on to the next exercise. Okay, now it's just stopping. Okay, this is a Swiss ball or a medicine ball, exercise ball, a little more challenging. Okay, you actually have to have better core muscle strength and balance to be able to sit on this ball without falling off, and then you're doing your rotations. So we can modify this with very simple equipment, okay, and incorporate more strengthening. Okay. If that's too easy, here you go. 3-pound medicine ball. Same thing, maintaining your core, good posture, arms extended, and you're incorporating your rotations at the same point in time. Okay, you just do 5 each side. Here's Willie again on a Bosu, a Reebok Bosu. He's using a 3-pound medicine ball. Okay, there you go. There he is, bending the knees, coming across in diagonal patterns, working the core, working his back, and working his legs at the same time. Very simple techniques, okay? Same thing with us with TheraBand. Okay, working on those extensor muscles in the back, working on the scapular muscles, just working range as well as gentle stretching at the same time you're maintaining your core. So this is typically what a program would be like from start to finish. Some stretching, walking program, or fitness sort of exercise bike, etc. And incorporating posture, etc. in that position. So remember, we can modify almost any exercise that you can think of to fit you. The bottom line is motion is lotion, okay? Don't worry about rats, because you're human. Okay, that's my caveat from the morning. We don't have a specific exercise program. We have to tailor it to you because, like I said, if you don't swim, no point in me telling you to swim. If you like to play hockey, I can modify that for you. Okay. Any questions? I want to thank San Francisco. Loved the seafood yesterday. I was thinking I could swim across, but then I decided it's actually further. But it's a great, there's sharks. Didn't know about that. Maybe that's what I had for lunch. Any questions?
I have a question.
Yes.
Excuse me. I have a son with AS, and he sleeps on his stomach with his head turned to the side.
Yeah.
Granted, he's only 20, but any recommendations for better?
Sleeping hygiene, sleeping posture. I'm a prone sleeper as well. I sleep on my stomach with my arm over my head like this too. And at a certain point, it causes problems in your shoulder. If you can tolerate it, there's probably no downside to it. If you can encourage to break that, you have to, sometimes what we do is we put one arm inside the shirt or tie the wrist up with a belt to the side of your leg so you can't, it'll make it very uncomfortable for him to roll over in his stomach, and most of the time you end up in that position, right? With your hand over. So if you put your hand inside your shirt and leave the other one out, then you're not gonna be able to sleep. So we use different techniques to try to break that pattern and get him a good pillow. Okay, try to teach him either side lying. If you're a stomach sleeper, probably the easiest thing to do is switch to side lying.
Yeah.
And encourage him to sleep side lying, and then eventually we can get him to be supine on his back, because that again encourages him in that position. So we do it gradually. It's a very difficult pattern to break. Okay, speaking from my own personal experience, but it can be done. You just got to modify it to what's easier. And the next step would be side lying with the pillow. Make sure he doesn't get a lot of discomfort, and then eventually get him to move over to supine.
May I ask one more question? And I'm not sure if you're the right person to direct it to, but I'm just wondering if anybody has come across an app that is particularly good for tracking all these doctor appointments, changes in symptoms, exercise, that's easy to do,
There are programs online. Most of the time they're associated with a product or a drug. For example, if you have a Fitbit, you can have a Fitbit, you can have a tracker, you can track how much you're doing, it tracks it, puts it on your smartphone. There's other apps, and if you Google sort of inflammatory arthritis literature, you're not going to find it, so it'll be in the sports medicine sort of app, so a fitness app, for example. A lot of the drug specific manufacturers, at least up in Canada, have patient support programs. And a lot of the support programs, once you're on biologic, they have apps that they include once you're on drug to track, set goals, track when you're doing your injections, track when you're doing all these other things. So those are more dependent on, for example, if you're on a certain drug with a certain company, they each have their own. So they've developed a lot of those apps specifically if you're on drug. Okay, so they are available, and it depends on your circumstance, depending on whether he's on drug. But I would look at the sports apps first, like the Fitbits and the sports medicine stuff, because that's where all the tracking is usually done. Sir?
My question is, what exercise do you recommend to improve two specific areas? One is chest expansion, other one is neck flexibility.
So the neck flexibility is interesting. The one we recommend it depends on how rigid or stiff you are now. So if you don't have stiffness and you're not fused, the easiest thing that we recommend is to work two motions. One of them is cervical rotation, meaning you're just trying to rotate in this position to try to get your chin over to your shoulder. But the more important one, the one you typically lose quicker, is your ear to shoulder or your side flexion. So putting your hand underneath a chair, for example, because a lot of the time you're stiff, is we would recommend that you have something to stabilize and keep your shoulder down. So hooking underneath a chair or underneath your bottom of your leg to keep your shoulder depressed, and then leaning slightly away from your arm, okay, to get some support there, and then just bring your ear to your shoulder. That way you can get a little bit more of a stretch. So we recommend typically your neck retractions that we showed you the picture of, and then functional movement, rotation to either side, because most of the time you want to be able to drive a vehicle and do your shoulder checks. So we encourage things that are functional. Okay, there's a lot of other exercises you can tweak in there for the cervical spine, but if you work on side flexion, so ear to shoulder, and then rotation, the combination of those two movements is probably more functional for you to incorporate. Chest expansion, we recommend that anytime you're doing your exercises to include a deep breathing, diaphragmatic type breathing, or like a Qigong type exercise, a Chinese type of deep breathing where you're doing diaphragmatic breathing. You incorporate that at the end or the pause of your exercise. For example, when you're putting your arms up or you're doing your rotations, okay, we encourage you to take a deep breath in through your nose and then breathe out through your mouth. So you're trying to encourage that maximum chest expansion. And the other exercises where you're lying on the foam roll, working on stretching out your pecs and working your scapula, all those movements and all those areas will free up your rib cages.
Thank you.
Sir?
Can you suggest some exercises while you're walking to save time and energy? 3 for 1, 4 for 1 maybe?
So, 4 for 1. So I encourage to do the stretching, like we said, get up in the morning and do a walking routine. The Nordic poles or the walking sticks are actually quite good, especially if you're walking in a group. For example, if you got a partner or if you got someone else to go in a walking, patients really like them. One reason is so you do your stretching, you wake up, take a shower, do some of your exercises where you're on the mat, get up, do your gastrocs and soleus stretch, so you're making sure that you're stretching some of the muscles that you might need for your walking. The Nordic sticks, really, they're like hiking poles, but they're at a different slight angle on the bottom, and there's a way to use them. And really what you're doing is doing a reciprocal arm movement at the same time that you're doing your stride. And so that's incorporating some of that better posture where you're in a more erect position, as well as getting some upper extremity workout. So that's probably all you can do with the walking. A lot of those Nordic sticks also have TheraBands or resistance bands or tube, like a tube inserted in them. So you just really take the handle out, and it's got a stretch band like that. You put it on the ground, and you can use the bar and do an exercise program, every 20 minutes or 30 minutes as part of your break. So there's ways to sort of tie a resistance band in there to get your exercise as well.
Thank you.
Okay, ma'am, down there.
It's a question about swimming form.
Sure.
I've unfortunately gotten into the bad habit that I always breathe to the left, and I know it's important to keep everything even.
Yeah.
Any recommendations on either how to break that habit, or if there's some way to at least alleviate the extension of the neck?
It's a very good question, and I do not have a good answer for that. Once you're breathing, especially for swimmers, once you get into a certain technique early on, it's very hard to break that habit. And a lot of the time, you won't be able to break out of that habit, okay? Just because it influences your rhythm and how long you can do it. It influences how you're breathing. So what I recommend is just stretching appropriately to the opposite side, pre and post. So for the fact that you're always rotating to the right, or in your case to the left, what happens is you work one side of the muscles on a continuous basis, okay, and those will get usually tight, stronger than the opposite side. So you might have to incorporate a stretching program to stretch those muscles, so ear to shoulder and your rotation to the opposite side, as well as strengthen the muscles on the opposite side of the neck, so you're not imbalanced. Okay, so the fact that you're continually working only towards your left, you have to stretch out the left side and strengthen the opposite neck muscles. That way you're going to have symmetry. That's probably the easiest way than breaking a swimming habit like that with breathing. Okay, it's easier to just compensate by stretching the same side, strengthening the opposite side, so you don't end up with asymmetry than trying to break a swimming habit like that.
Thank you.
No problem.
My question is regarding the cracking in the mid back, and like certain exercises, especially the one with the cat-cow stretch. So I always feel like a cracking in my mid back, and it's like if I do it like 10 times in a day, it will crack 10 times. So what do you think about it? And is it good in a long term? Because my rheumatologist says that I should not be doing it, but my physical therapist says that it could be a good thing that it's happening.
I didn't catch the first part of your question. You mean the extension exercise?
No, the mid back, it cracks like it.
Oh, the manipulation of the back. Yeah, that's something we don't recommend. That's something we don't recommend. Now, if you're doing it on your own, and just sort of, rotating and you feel like a little snap or, a little crack, you're not probably manipulating your own spine, right? You're just getting you're sort of doing a little adjustment or subluxations of your own spine. So you're probably not doing any harm, right? The ones that we worry about are the high velocity thrusts that you would get your physio to do or your chiropractor to do, where they're sort of long levers or even short levers of your neck. So it's an external force applied to you. So we don't recommend someone manipulating your neck or putting you in a position, for example, to manipulate your lumbar spine. We put you on the bed, rotate you like this, and sort of crank on your knee here to try to get you to manipulate in a rotation movement. That type of manipulation is something we don't recommend. But you just sort of going like this, popping your back like I just did, it's not going to be harmful to you. Okay?
Okay, and as long, I mean, the frequency does not matter in a day if it's like 10 times or 20 times, because it happens on its own. I don't try to do it, but it happens on its own.
It just, so sometimes that's what we call, sometimes it's instability, meaning that even though you're rigid, you might have some excess movement in that range of motion. Imagine just like a cup or a saucer and you have a little marble in the middle. So you're getting that marble to move from side to side, but it's within that cup. What you might need to work is more on strength to keep those joints from moving, okay, versus stretching them more. So certain cases, depending on what the condition is, we try to give you more stability exercise to strengthen the spine to keep them from clicking or popping like the way they do. Okay, so although it's not harmful, it just means that you might be doing something that's maybe annoying to you, and it's sort of feeding back to you. It's not going to cause any harm, but I would probably recommend in that case to do some strengthening, some core work of those muscles, rather than continuing to self-manipulate yourself.
Okay, just to add one more thing, like my rheumatologist said that it could be the calcifications, like whenever I snap it, it could be the calcifications because they are very thin. It could be breaking up or something like that. So is that a possibility? Is it harmful in a long term if I don't know what is happening?
You need so if it's the ligaments, if you're getting ossification in the ligaments or the syndesmophytes up from one part of the spine to the other side of the spine, I don't think that you'd be manipulating those 10 times a day, because that's extremely painful. If we fractured through one of those syndesmophytes, believe me, you would feel it. You would be doing it once and you'd be in pain for a long period of time. Okay? So my guess is that you're not tearing or you're not breaking the ligamentous structure or the syndesmophytes. That's something we worry about with the manipulation, right? My guess is that what you're doing is you're just getting a little excessive movement over there, and you have to work on the strength around the articular function versus tearing a ligament or calcification.
Okay.
It's really hard to do on your own.
Thank you.
Problem.
Hi.
Hi.
I have a question about cardio exercises.
Sure.
When I typically do any exercise that's cardio related, my hands and feet get really hot and swollen. I'm not necessarily in pain, but it's just uncomfortable. And I noticed that the swelling isn't from pounding or anything like that, because I could be on a stationary bike and my hands still get swollen and my feet. So my question is this something that I should work through and just keep going, or would it be beneficial for me to take breaks and then keep going? So I'm not sure, because it happens during any cardio exercise, and I don't want to not do cardio exercises, so.
What you're describing, I wouldn't be too concerned about. That's very typical, but it's very hard because I don't know your current status. So sometimes you can get dactylitis or swelling in your joints with spondylitis or psoriatics. Okay, so I don't know if there's any psoriatic spondyloarthropathies here. So you can get dactylitis, so sausage fingers, sausage toes. Mm-hmm. Sometimes exercising, you can trigger that, and it's it just looks like a sausage, like extreme swelling. In that case, we tell you to limit how much exercise you do until its swelling goes down. But in your case, it sounds like it's just a fluid sort of imbalance kind of thing, and it's not related to the underlying disease process. I would just break down your exercise routine to a little bit less and make sure you're just hydrated. It's probably just a fluid thing.
Yeah, I think it's circulation, because I walk like this and I feel better.
Yeah, that's my guess. Because if you get that, flare in some of the spa conditions, or for example your Achilles tendon, it's very difficult. It doesn't just go away.
Right.
Right away, and then you start up another routine half an hour later, and it happens again.
Right.
You sort of there's a latent period, and then it stays for a long period of time.
Right.
So my guess is in that case you're just sort of fluctuating with your fluid imbalances. I wouldn't worry about it too much.
Okay, thank you.
Yes, ma'am.
My question was that I used to do track and field before, and what made me stop was that I would be running and I would feel fine while I'm running.
Yeah.
It was when I stopped that, or like I sat or I lay down, that I would just like kind of instantly stiffen. Like, it would be like 10 minutes and I would start cooling down and I would start to like really get stiff, like real bad. And then I would just be like, or even now, if I keep moving throughout the day, I'm fine. But when I'm like at the end of my day, I'm like, I'm not going to go anywhere. I'm laying down, you know. I guess, is there anything really that can help with that, I guess, like some type of stretching or?
I think the best thing to do is make sure that in the morning you're doing a small component of your initial day is to stretch and sort of get the joints ready for movement through the day. At the end of the day, doing some of the postural stretching or the TheraBand or lying on the foam roll helps just reset the body after being in a flex position or after exercising. So doing a stretch at the end of the day might help. Even a couple exercises, for example, for your neck, your lower back, and your legs, for example, your hamstrings, that helps sort of relieve some of that muscle tension and fatigue that might be occurring all day. The other thing you can do is try, example, at the end of the day, depending on what you do all day or your job, you might want to take a warm bath, warm shower, and just sort of, that has been shown to help with stiffness as well. So you can mitigate some of that. The other thing is depending on what your physician recommended during medication-wise, occasionally what happens is if you're having those symptoms just at the end of the day, what we do in our clinic is make sure you take your anti-inflammatory medication and you time it for the end of the day when you're getting those symptoms. So example is, end of the day, we have some clients that are stiff at the end of the day. During the day they're fine, but they're finding that the last couple hours, after they have their meal, very difficult for them to sort of wind down and get to sleep because they get very painful and they get stiff. So they take their, diclofenac, or they take their Celebrex, or they take their Aleve, whatever you have over here, take their anti-inflammatory at the end of the day there. So by the time it kicks in, they're able to sleep and modify and carry on. So you might just have to discuss that, probably not with your physio, but with your physician to see when the optimal time to take your analgesic medication or your non-steroidal. So that's probably more of a question for them. From the physio side, doing exercise at the end of the day, even a stretching program, has been shown to relieve stiffness as well as relieve sort of that sensation of pain, and it's been shown to be better for your sleep, as long as you don't do it at midnight. Right? I'm assuming the end of the day means between 6 and 9, you're going to do a little stretching, a little walking. That's probably going to be better for you to incorporate and feel better after stretching and doing all that to allow you to sleep better.
Okay, and sorry, one more thing. I guess I do the same thing that the guy does, but I kind of don't crack just in my back. Like, I'll feel it in my neck, and I'll want it, kind of everywhere, honestly, like my hands.
Yep, just like
and
that.
my hips, yeah, and I'll be like.
Recommend you don't do it. I know it feels good, and what we do is usually you're just subluxing some of the joints. You're just causing sort of cavitation within those joints, and most of the time it's okay to do, but we don't want you to do something over the long run repeatedly because we don't know the effect of that. Right? We don't want you to go the other side where you're getting instability in those joints. So if you're doing that repeatedly and it's that easy to do, that's why we recommend that you work on a strengthening or core strengthening program, so it sort of keeps the spine in a better position, so when you're doing those rotations, you're not able to do that, or you're extending your spine and you're not manipulating yourself. Which you're likely not, you're just probably subluxing some of the joints. Yes.
Thank you for your presentation, it was wonderful.
Thank you.
I have two small questions.
Sure.
One, are most physical therapists schooled in AS and these conditions?
Yes.
So when we go to a physical therapy, they're supposed to know a
You should.
program for
You
AS?
should, yeah.
Okay.
It's difficult, and the reason is so yes and no. Okay, just like in this morning where you heard that depending on who your rheumatologist is or depending on the expertise over there, your physician might have more experience within one body of knowledge or field. So, any rheumatologist or even any family physician should be able to identify mechanical low back pain and inflammatory back pain, right?
Right.
Because how do they know it's inflammatory if they don't know what degenerative looks like or mechanical? So ideally they should, but there's this delay in identification and treatment, right? So considering most patients go to a physio or chiro initially when they get back pain, you would assume that if they can't manage it and it's not mechanical, that they would be referred to a rheumatologist to get their disease diagnosed. Mm-hmm. So ideally, yes, the training is there, they should be able to identify it, but it doesn't happen. So you have to really look for someone who I recommend usually that's working in that field. okay, because you become subspecialized. If you're working in an outpatient ambulatory care setting, sports clinic that just does hip arthroscopy, ACL reconstructions, you're probably, not going to pick up spondylitis.
Okay, thank you.
Okay, so
Second question.
I think you need to sort of just focus on finding someone in your geography that knows. And a lot of time, you don't need regular visits. It's getting initiated in a program. You got to do it for 4 to 6 months. Maybe see them, once or twice. Change the program, or if you have a flare, they can go modify it. So we don't encourage you to see your physio or your chiro on a long-term basis, sort of every 2 weeks for life. Okay, we're trying to promote, appropriate posture, appropriate exercise, fitness concepts. When you have an issue, for example, with your feet or your Achilles tendon or your shoulder or your neck, you come in, short, limited time to sort those symptoms out, and then back on a routine, a program that you can do on your own. So that's the type of lifestyle long-term management that we encourage. And most of the time, you can probably find someone in your geography or geographic area that you might have to travel a little bit further, but you only have to do it once or twice a year. It might be worth it.
Thank you. The second question is, is there any magic for heel pain?
It depends on the origin of the heel pain. So if it is, that's a hard question to answer. So if you've got a flare and you've got an enthesitis type related pain and you're in a flare, you never had that pain before, you might not be responsive to the medication that your rheumatologist put you on. For example, if you're perfectly stable and it's not exercise related, for example, you didn't decide that you're going to start run or jump or do something, or like me, walk towards the wharf up that massive hill or two, I've got heel pain today, right? Is that inflammatory arthritis? No. But if you're stable, for example, and you're only on a non-steroidal, and something's changed, and you have it on both sides or one side, and it's swollen, it's painful to walk on, that's something that we encourage you to go back to your physician earlier than just leaving it, because there's probably some underlying inflammatory condition. You might be your inflammatory markers might be elevated, and it might be that you might need something else. You might need to step up and go on a TNF inhibitor. At least that's what we do on our site. There's some of the TNFs are better suited for enthesitis-related conditions, or at least that's the way they're marketed, uveitis, etc. So if something's changed and you are stable, that is something that you should go back and ask your physician to reevaluate, because you might need to go on another mode of treatment. And that's the way we would approach it. But that's why it's also good to keep a log of what you're doing. And don't go running back and say, doctor, my heel hurts, but it was because I walked up and down San Fran to the wharf like 5 times, right? Okay. Like there's a cause and effect. But if you can't track it, there's been a status change, Or, for example, if you're on a TNF inhibitor for 5 years, and then your fatigue levels have gone up, your pain levels have gone up, you're getting heel pain, you're getting, knee swelling. It's time to go back and reevaluate. There's no harm in that, especially if you haven't there's no mechanical origin to that pain, because maybe you've lost, the effect of that drug, and you might need to be switched. So I think really you have to separate on things that you can do physically on your own, and then relate your symptoms that you're feeling to either that cause, or if there's nothing related, there may be feedback to your rheumatologist just to have an eye and figure that out. Heel pain is very difficult, but occasionally if you're having anything both sides, for example, both your knees, both your heels, both your Achilles tendon, it's usually not a sports-related phenomena. For example, most patients that come in, they get flagged with low back pain and bilateral plantar fasciitis. That's a red flag for us in a 40 or year-old male and lower. You don't get bilateral symmetrical plantar fasciitis in, for example, a 20-year-old that's inactive. We usually it's something that we sort of look out for to try to evaluate on a semi-urgent basis.
Again, thank you very much.
No problem, thank you.
Could we, I want to be respectful for some time,
Sure.
so I don't know if you could stay after and ask
I can,
a couple
yeah,
of questions.
feel free to.
If we can ask him some questions after we wrap up, but we have some people I need to thank, and I have
Perfect.
six
Thank you.
announcements. First of all, thank you again. Lotion, what was that? So we have the exercise DVD if you want to get started on that. And then in our Straight Talk magazine, or our publication Straight Talk, we have exercises there listed and a poster. So they have these outside, and you can find out about those outside. Wanted to recognize a couple support group leaders. We have Carice here, who's in Sacramento, and Jill over here. It was local, right? San Francisco. So if you want to know more about educational support groups in the area, let them know. And I'm in Los Angeles, so you can come see me about that. And then I want to thank Reiner for the sound and the video. Thank you. And Matt for the streaming, and the hotel for taking care of our other needs. I want to thank Diane and Christy outside with help with illustration, and Aline, of course, our director of programs, for putting on this activity. Everything that went smooth and right, that was her doing. And then, parking. So if you parked here in this hotel, it's more expensive than not. But we have stickers to reduce the cost of that to $21. So come see me about that. And then once again, I want to thank everyone for their participation today, and I look forward to continuing the conversation. Sorry? Oh, we need the so are they already distributed, or are they here? So you should have feedback forms for you. And then the online folks, there's going to be a way for you can give feedback also. So those are very important for us, and I appreciate that. And take your feedback forms to the registration desk outside or to Aline. Thank you again.